اوركيديا حلم مصري اصيل بدأ من 25 سنة. انطلقت سريعاً لتتحول من شركة محلية لشركة عالمية ليها أكتر من 30 فرع في 30 دولة أجنبية، وتتربع على عرش الصدارة في المركز الأول على مستوى مبيعات السوق المصري، والمركز الثاني في دول غرب أفريقيا في مجال أدوية العيون باستخدام أحدث التقنيات العالمية في خطوط الإنتاج. وفي 2019 بدأت اوركيديا في تحدي جديد في مصر والشرق الأوسط بإدخال أول خط إنتاج مصري لتصنيع القطرات الأحادية، الجرعة الخالية من المواد الحافظة، لتسلط الضوء على الفرع الوليد في طب العيون، وهو أمراض سطح العين واللي بيغفل عنها الكثيرين. وفي 2021 أطلقت سيزا إمباكت لتقوم بأول مشروع علمي بحثي لدراسة أمراض سطح العين ورفع الوعي اتجاه هذا التخصص الحيوي وتعريف التأثيرات السلبية لاستخدام المواد الحافظة على سطح العين وعلى جودة حياة المريض، وإبراز أهمية استخدام القطرات الخالية من المواد الحافظة من خلال عدد من الفعاليات العلمية، وعلى رأسها أول وأكبر تجربة بحثية في الشرق الأوسط لدراسة التأثير السلبي للمواد الحافظة على سطح العين وجودة حياة المريض.
Thank you for all the work you've done with us. Actually, I'm so happy today that I see that we have people or doctors coming from the UAE, from Jordan, and from Egypt, and most importantly from Greece, the host country. Actually, I will not talk too much. I will just welcome you. I will just explain to you how do I feel. I'm feeling very happy for one reason, that we planned, we could deliver what we planned for, and we could reach to this point which we promised ourselves that we will reach it, to celebrate finishing our first phase of our study and to deliver this piece of science to the coming generations. This is something I am proud of, that we could, as industry, celebrate this and cooperate with the scientific centers and the professors and deliver something to the young generations which might help in making the lives of our patient more easy and the lifestyle more healthy. Thank you for coming again, and I will leave you for your program, and thank you for listening to me.
Thank you, Dr. Osama. Now I'm inviting Professor Mohammed Shafiq, Professor of Ophthalmology at Alexandria University, for the presentation of See the Impact Project, the story and the futuristic aspiration on behalf of the OSD Consultancy Board.
My dear and esteemed colleagues from Egypt, from every city of Egypt, and on top of them, Dr. Sam Lazarag, of course, from Algeria. It's a pleasure and honor to speak on behalf of my colleagues, the board of the ocular surface disease in Egypt, to celebrate a very important celebration today, the results of our dream of having the first clinical trial in Egypt, a true clinical trial in the field. And let me take you into a journey through the past 3 years to explain to you how difficult was the situation and the vision and the mission and how did we all achieve that. Again, welcome you all in the city of Athens, the great city that I love.
Many thanks to Professor Dr. Mohammed Shafiq for this great presentation as usual. And now I want to invite Professor Siham Lazarag, the TAFOS ambassador in the MENA region, to present the clinical trial results.
I know that all you are waiting for these results, but before announcing the results, I really would love to thank Orchidia for giving me the chance, the honor, and the opportunity to be part of this project. Actually, this is not a project, it was an adventure, because we started from nothing and we did a lot. Thank you to giving me the chance to work with this dream team, with this very prestigious panel and board, and we did a lot of good things, and we have very nice memories, and I hope that we will have more and more. And now we have the confirmation in our clinical practice. Then when we move to a preservative-free treatment, the symptoms, the signs, and all the adverse events disappear, and we will have more compliance and more quality of life. Then, as a doctors, our primary goal is not to harm our patients. It's to preserve the health of our patient, and this is my conclusion: primum non nocere. Thank you.
For me, it's an honor to be among colleagues that probably they have almost the same history, the same style of life, the same beliefs. And I'm speaking for the countries that are around the eastern part of Mediterranean. I feel that we are all somehow brothers, and for me, it's much easier to go to Egypt than to go to Athens because I'm from Crete. And always, by way, my home village is looking to south of Crete. So when I was a child, I'm telling you, every night we're hearing radio, and we cannot capture the Athens radio station. We capture all the Egyptians and the Libyan stations. So I was hearing Arabic songs all my life when I was young. Now, the history comes much before, let's say, the classic Greek history was Athens and all the philosophers you put on your screen. And we are Minoans. That's been many thousand years before the Greeks. They come up with Acropolis. And the Minoans, they have much closer relation and habit with the Egyptians. They have a very close connection all the time. So I like to come back a little bit to the history because somebody tries to give the history of tear film quality and the tear film and the drops. So the history is much longer, not like 1,800. So here you see that we have for the Asio-Babylonian ophthalmology description about the dry eye and how you can treat the dry eye. You see? With onion and drink a beer and on and on. So you see, Orchidia has a much longer probably history behind before you came in the business. And even 1872, when the German George Ebers, which was an Egyptologist, by the way, described about the quality of the tear film and the drops they're using, this comes back for 1,500 BC, and it comes from Egypt. So in one other way, I think we have a long history with drops in the eye, and that's why your company succeeded, by the way, because you have the history back from you. Now, let's say the best achieved visual acuity, all of us will know, of course, is with the use for the hard contact lens, all right? If you like to see what is the best performance on the eye in a sense of the visual acuity, and you're not sure about your refraction, and you're not sure if the patient probably has a kind of maculopathy which cannot be detected, you put a hard contact lens and you see how the eyes perform. And of course, for patients that don't have cataract, all right? So if we are trying to have the optimal, let's say, cornea surface, we have to have a surface which mimics the hard contact lens surface, an absolute sphere.
Very important for me was the quality of study that has been conducted in Egypt and the quality of medications that had been produced in your area. And I think it shows one thing, that in the area, in Mediterranean, in the north of Africa and in the Middle East, we have a lot of potential. We just need to think about the potential and work for that. And my presentation here is a little bit, not too much on ocular surface. And I will share with you some of my thoughts and the things that we have done in replacing and in trying to find a solution with the shortage of tissues that we have when we try to do transplants. So new concepts in stromal surgery, basically, just a few things. The basic thing is corneal stroma is probably tear breakup, tear surface, tear film is the first surface, but let's say that after that is the epithelium, but the corneal stroma has basically optical properties that we have to make sure that we maintain when we do the surgery. You can see how complicated is corneal stroma, and you can see that in different layers of the stroma, different thicknesses are of the fibers of the collagen. So it is very important to understand why it is very difficult to try to manufacture, or let's say to imitate nature. It is almost impossible. And this is a slide that just shows this basic knowledge that we have on corneal stroma. Now, what is the body itself is doing to try to regenerate it? They have, for the epithelium, it's a simple cycle of apoptosis and division. But for the stroma, we don't have this kind of luxury of quickly apoptose and repopulate. So we have a very slow turnover of collagen and some of the extracellular matrix, trying to maintain the healthy stroma and maintain a good vision. So how can we replace stroma? What are the problems, the task when we try to replace stroma? Most of it is the scarring. The scarring at the interface, when we are faced, when we do the bulk, the change in the refraction, whenever we try to do whatever we try to do on the stroma, there's a change in the refraction, which is sometimes very difficult to correct. And of course, the immunological reaction. I think these are the most important things, plus the problem with nerves. And with nerves starts the problem of dry eye and all the others. So what are the options? The first option that we all know is replacing with anything sparing endothelium like DALK, FALK, and all these new things.
The manifestations of the ocular surface disease are so many, as you see, varying from punctate keratitis, tear film instability, allergic features, pseudopemphigoid, dry eye, blepharitis, and vortex keratopathy. And it's basically related to, as Dr. Siam have just mentioned, to the preservatives, which is BAC. Yes, BAC is doing something good, but at the same time doing a lot of harm to the ocular surface. Now, when we look at the patient with glaucoma, and actually our main mission is to preserve the optic nerve, yes? And that was actually, we think of the visual field, we think of the OCT, but we forget the ocular surface, and that's a big problem. But nowadays, we pay a lot of attention to the state of the ocular surface because it is just, the presentation of the patient.
Fancy machines can facilitate the task too much, but they are expensive. But with a single drop of fluorescein, even if we are in a remote area or an unqualified or unequipped clinic, you can do marvelous things. You can see the staining, which is a very important thing, and you can measure the tear breakup time. And I think the tear breakup time, the classic one, is very crucial. The Schirmer test is a bit tricky. Many of us don't know how to collect properly the data from the Schirmer test. If some of us do install a kind of anesthetic which give wrong results. Some of us make the patient close his eyes, again gives a wrong result. And many of those patients have a watery eye on the opposite, not a dry eye. So it's not that informative.
So a single drop of fluorescein, which has the biggest advantage of allowing measurement of the intraocular pressure at the same time. So that again, just fluorescein drop and tear breakup time could be satisfactory. Then when we think of other modalities, then Dr. Tamer, would you comment on, are you going to do a kind of myopography, other imaging modality for every patient?
For my practice, I use the fancy machines for dry eye assessment. And I think these are very helpful for diagnosis of dry eye, because as we know that the meibomian gland dysfunction is the main cause of dryness. So we have to examine the meibomian glands properly. We have to examine the precorneal tear film. This means that we have to have these machines, because without these machines, we cannot examine the meibomian glands and the precorneal tear film. I think they are very important, and they can diagnose many cases of dry eye, even with minimal symptoms.
So is it routine in your assessment?
it's not that routine, but in patients with suspicious dryness, I go to these machines.
What we were all talking about in the previous lectures, that dry eye disease, we see it a lot. All of us who does surgeries see these patients. And the most important thing, that dry eye affects the quality of life. Let me ask Professor Parikaris about how can OSD impact preoperative decision of surgery.
I believe speaking for always for older, let's say, patients that are candidates for cataract surgery, in general, they have some degree of dry eye in any case. Now, the point is how this may affect before the surgery the quality of life for this certain patient.
It's very important to keep in mind that the problem of the dry eye in evaluating and taking seriously the measurement of the biometry. So how this can affect the biometry?
Can affect all of the key reading of the optical biometry. This is the problem. You have to put, if the patient has a dry eye, you have to put many lubricant to get the proper key reading, and you have to repeat it maybe with ultrasonography if you're not sure about the key reading to get the optimum IOL calculation. It's very important.
So it's very important that we should evaluate and make sure that our readings, even if we do topography for the cornea, because if you take multiple measurements for the key readings, maybe this is very important for the biometries. You have to make sure that this is correct. And we don't rely very much on the key readings on the IOL master only, particularly in premium IOL, premium IOLs. So Dr. Ahmed Assaf, how can the ocular surface disorder impact the choice of IOL among all this myriad? I know you have a lot of experience of these premium IOLs.
Yes, we should address the dry eye ocular surface disease before taking the biometry, because I've mentioned from the second question, it affects the key readings and affect the astigmatism as well, the corneal astigmatism, not only the magnitude but also the axis. So if you are assigning a toric lens, like a premium lens for this patient, you might end with ametropic surprise after the surgery because of the wrong calculation or wrong measurement. So I have to address the dry eye first, and then addressing the dry eye aggressively, I might choose the type of the IOL. If I can control the dry eye before the cataract surgery, I might assign this patient to a premium lens like the trifocal lens. Or if the dry eye is not very well controllable, maybe I'll go down to the EDOF lens, extended depth of focus lens, or otherwise I will go for a monofocal lens.
Dr. Seham, how can ocular surface disorder impact the postoperative results as regards the vision and comfort of the patient and the possibility of incidence of complications even?
Now we have many tools to measure the quality of vision, not the quantity. Then in patient having OSD, we have when we have a straightforward surgery with a very nice results, we have the quantity of vision is 20/20, for example, but the quality is poor because the tear film is the first diopter of the eye. And if we have a poor tear film, we have a poor quality of vision, then the patient will complain, even he's seeing 20/20, but he will complain about poor vision.
Okay, thank you for the great panel. Thank you for your help. Thank you for your attention.
I want to invite Dr. Osama Abbas, Orkidea CEO, and I want also to invite our dear guests, Professor Ioannis Palikaris and Professor Meltos Balidis, for a memorial gift from the Egyptian civilization.
The new civilization, imitation of our old civilization. That's